Buongiorno.
Hi, buongiorno, Azim. How are you?
Good. How are you?
I'm fine. Nice to see you.
Nice to see you too, Salvatore. Sorry we're running a little bit late with rounds this morning.
No
Um,
problem.
Come on. So thank you for joining us. I really appreciate it. I know things are heating up for you back in Spain. So I really appreciate the time you take out. I also have Juan with me. We work together on Tuesdays at least, and sometimes even more. um, so
I will get
yeah,
confused between languages, no? Because your secretary speaks Spanish.
yeah.
Juan also speaks Spanish, so
I speak Italian, but we're going to
you
do this
speak
in
Italian.
English so that our colleagues can follow. So, Salvatore, thank you for joining us. So we're gonna get started. Thanks everybody for joining. Salvatore is from Barcelona, Spain, but he's Italian, obviously, Brugaletta, and I've known him for a long time. He's one of the people who's been really truly an expert in really stent choice and STEMI, and has done a number of very important studies that have changed how we practice, both with DES as well as with BVS. So it's a real pleasure, Salvatore, to have you join us, and we look forward to your talk. Thank you.
I mean, thank you, Azim, for inviting me to this very interesting session that you are doing since many, many months. So, I'm a fan of you and also of this initiative. So, congratulations, for making this. So as you said, so I will try, to make some story about the stent choice in ST elevation MI. So these are my conflict of interest. So first of all, this is a typical case of ST elevation MI that is usually seen in our practice. And every time that we see such a patient, we always think, to make the procedure as safer as possible, as faster as possible. But one of the choice that maybe we are not thinking much is about which stent to implant. Just give me a stent. Usually we say to our nurse, to our lab staff. So I guess that every time that we have to implant a stent, so in a corporate STEMI lesion, we have to think about three different factors. The first one is that we are treating a thrombotic lesion, so in which there is some thrombus, and also a STEMI patient is a patient with a thrombotic environment. That means that the activation cascade is active. So, and it is not only a problem, a matter of the thrombus present in the lesion, but it's a matter that the patient is producing thrombus. Second point is the fact that sometimes we have to deal with the vasospasm. That means that the lesion is in a vessel, so with a diameters which maybe is less than the real diameters. And third point is that we have to think about the safety of our patient, the safety of our procedure. So taking into account not only stent thrombosis but also bleeding risk. So the best stent should be a stent in which we don't have any problem with the thrombus which is in the lesion. So also because the stent will be smaller, although we are trying to oversizing due to the vasospasm, and also should be a stent with a very low risk of thrombosis in the acute phase. So the work, our work is easy after these 2017 guidelines coming from the ESC, which actually upgraded the recommendation for the stent to be implanted in ST elevation MI from bare metal stent, so giving it to drug-eluting stent, the maximum level of evidence, the maximum level of implantation. So actually, we have now the drug-eluting stent, which is the STEM treatment for ST elevation. However, so here this is the story in 2017, but it was not like this. So in the previous years. And actually, so if we start, for example, in 2004, this was published by Ron Waxman. So every time that we were comparing stents for on-label and off-label person, so implantation and for off-label situation, so we think about the saphenous vein graft, in-stent for stenosis, acute MI as well, but also CTO, left main, and three-vessel disease. You see here that every time, so that we look at the success of the implantation, but also the rate of death, QMI, no QMI, TVR, and thrombosis, the risk of these events every time that we are talking about off label was quite high, higher than in label situation with a p-value which was significant, you know. And this was the reason why in those years, so there was the first study which was published in the New England, which was the Typhoon trial, so which was comparing the drug-eluting stent which was available at that time, which is the Cypher, so a thick drug-eluting stent, so 150 microns, compared with any bare metal stent. So the study was powered for target vessel failure at 1 year, and actually the aim of this study was to see if looking at the off-label implantation in a primary PCI, so the Cypher, a drug-eluting stent of a first generation, was superior to any bare metal stent. The results were actually, to me, quite impressive because looking at the 1 year rate of the first endpoint, which was target vessel failure, so you see that there was a 50% reduction, which is something that we are not used to see in many studies in this endpoint. So going down from 14% of this endpoint to 7% of this endpoint by implanting a sirolimus-eluting stent. And looking, I mean, specifically at this at the components of this primary endpoint, so this was mainly driven by the rate of TLR, target vessel revascularization. In those years, so also another study, the patient trial, was done. So comparing, in this case, bare metal stent, not with a sirolimus-eluting stent, but with the paclitaxel-eluting stent available at that time, which was the Taxus. And you see that also in this case, so although the primary endpoint was not significant, there was quite a reduction, I mean, in the primary endpoint. So the story so was seen as the same. So at that time, so we put all these studies and many others together in a meta-analysis of the first generation drug-eluting stent in STEMI. And as you can see here, so every time that we compare, so the drug-eluting stent first generation versus bare metal stent, so the TLR and the MACE was superior for drug-eluting stent as compared to bare metal stent. So this was 2007, more or less, and we were all convinced so that the first generation drug-eluting stent were the best in class treatment for our primary PCI patients. However, so looking, I mean, at a longer follow-up, so for example, going after 1 year, so after 2 years, so there were some studies, like for example, this one that I show you, looking, I mean, at this landmark analysis after 1 year. And the interesting fact was that, I mean, at a longer follow-up than 1 year, so the rate of events in drug-eluting stent was actually crossing the curve of the bare metal stent. And at the end, so we get more events with the drug-eluting stent first generation as compared to bare metal stent. The same, I mean, here in this another meta-analysis published in 2012, so you see that every time that the follow-up was restricted to 1 year, so the things were good for sirolimus-eluting stent and paclitaxel-eluting stent of first generation, but every time that we were from 1 year to the maximum time of follow-up in those studies which were available, so we face a higher rate of definitive stent thrombosis and also definitive probable stent thrombosis. So why, I mean, these things happen? So we can explain so these results. So there are several factors. So the first one was actually the delay in the industrialization of the drug-eluting stent of first generation. So you see here that so after 12 months, so 2 years, 3 years, there is still some delay in the industrialization of this drug-eluting stent as compared to bare metal stent. And this was still more important. I mean, looking at how this device are healing at the level of stable lesion and also thrombotic lesion, as I said at the beginning. So every time that we implant a drug-eluting stent in a stable lesion, so there is some fibrous tissue, and here we see below in this slide, so that there is, I mean, a good healing process. So with the stent, which is covered, and this is okay. But every time that we implant a stent in a stable plaque, like the one that is usually seen in the MI, so which is rich of necrotic core, of some lipids, So the healing process is delayed. So it's not only, I mean, a matter of the drug-eluting stent versus bare metal stent, but it's also a matter of the lesion that we are treating, I mean, in this kind of setting. And this was the reason why there was some progress in the DS technology. You see here in the first generation drug-eluting stent on the left-hand side of this slide. So these stents were actually thick with some polymer, which was most of the time durable. And the drug user was not, I mean, totally biocompatible. And then so we switched, to second generation drug-eluting stent, in where we have not only, I mean, biodegradable polymer in many of them, but also more biocompatible drug, more biocompatible polymer, and the strand thickness was much less in this case. So we reached actually 60, 70 for some of them, as compared to 150 microns of the first cipher. Actually, the cipher has a thickness which is comparable to the one of the Absol, for example. I mean, to give you an idea. And looking, for example, at some of the characteristics of this new generation drug-eluting stent, so for example, the strut thickness, every time that we have a thin strut, so we can create a different shear stress. This shear stress is important because if we have a low shear stress, so we can create some thrombus. If we have a high shear stress, so the flow is very fast, and so it's very difficult, I mean, to have a thrombus form on the top of the strut. And there was, for example, a study published in Circulation 2011 showing, I mean, on one side, the science V, which was 100 micron, and the other side, so two different versions of the multi-link vision, so of the bare metal stent. So these two versions were different only for the thickness of the strut. And it was interesting, I mean, to see that it's not only, I mean, a matter of the fact that the vision thin, so is not drug-eluting and the science V is drug-eluting, but also was a matter of the thickness of the strut. So every time that we have a vision with a thin strut, so we can have also less thrombogenicity as compared to the vision with a thicker strut and as comparable to the science V. And this actually was really useful because comparing, I mean, the utilization of a second generation drug-eluting stent, like for example, the Science, so with the Cypher, Taxus, Endeavor, all the stent generation. So you see here some nice images of the nice utilization of this stent as compared to the other ones. And also the fact that it is more difficult to see some fracture of the polymer because the polymer is more stable. And a different image that we see now, so if we do, for example, an OCT when we implant a new generation drug-eluting stent, so is here. So at the time of the early drug-eluting stent, so drug-eluting stent of first generation, so every time that we were doing an OCT, so we were seeing an image like this, which was called a sort of cauliflower, because it was an example of this disruptive healing process following early first generation drug-eluting stent implantation. And this image is rarely seen for the new generation drug-eluting stent. So after I've made some story about why we went through first generation to second generation drug-eluting stent, so now we go to concentrate to the second generation drug-eluting stent, and this was 2008 more or less, and Manuel Salvatore actually so decided to perform this study, so the examination trial, which was the first study, so prospectively randomized, so comparing a second generation drug-eluting stent versus bare metal stent in primary PCI in STEMI. So this was a study including 1,500 patients, so randomized 1-to-1. And the primary endpoint was patient-oriented endpoint at 1 year, which I can tell you that was not superior, but looking here at the longest follow-up available, so that 5 years, you see that this primary endpoint was superior indeed. So with a very low rate of events for science as compared to multi-link vision. Looking specifically at what was the difference between the first year and from 1 to 5 years, you see that from the statistical point of view, so none of these endpoint was superior. But so we see that there is a progressive, reduction in terms of in terms of the patient-oriented endpoint. So during the first year, and especially after the 2 years, so after the 2 years, the curves are clearly separated. So here, it is important also to say that the patient-oriented endpoint, so is not related to the stent, because so the patient is, as the endpoint says, so is oriented to the patient. That means that it takes into account all-cause death, any MI, any revascularization, which are not dependent from one stent that you are implanting in the acute phase. Whereas the device-oriented endpoint, which was so the composite of cardiac death, target vessel myocardial infarction, and target vessel revascularization, was actually superior at 1 year and also at 5 years. Looking specifically at the definite probable stent thrombosis, which was actually the problem of the third generation drug-eluting stent, here you see that so we have quite less incidence of this stent thrombosis up to 5 years. And it is important to see the blue part of these bars, which is the acute stent thrombosis, which was very much in favor of the everolimus stent as compared to bare metal stent. And it was a statistical significance in this comparison, which means that the everolimus stent was safer in the acute phase as compared to bare metal stent, in which arm occur many stent thromboses. Here you see again, so at 1 year, the definite probable stent thrombosis was much better for the everolimus eluting stent, and thereafter, so we don't see, any difference, at least from the statistical point of view. Although, the percentage are still in favor of the stent. And now, so we have just presented 2 months ago at the TCT Connect the 10 years follow-up of this study. Just because we were struggling about the neoatherosclerosis, about what was going on. So after 5 years in this STEMI, and also because every time that we include patients, we enroll patients in a study, the patients are quite young, but in the life expectancy of this patient is much longer than the usual 5 years follow-up, which is used commonly in many trials. And you see here that at 10 years, so there is still some, so the drug-eluting stent, the everolimus stent, are still performing much better the bare metal stent. So the p-value is significant, and the curve is still parallel. So we don't have any attrition of benefit to one arm up to the other. The most interesting part of this study came from the landmark analysis. And let's focus, on the right part of these 2 graphs. So the ones which is showing the landmark analysis from 5 years to 10 years. So you see that after 5 years, so the 2 curves are quite overlap each other. So that means that, so if we see, a benefit of the everolimus stent as compared to the bare metal stent in terms of the either patient-oriented endpoint or device-oriented endpoint, this is given to the first 5 years of follow-up, let's say. But after 5 years, so the 2 stents are so quite the same. So we don't see, any better than the others. And in addition to this, looking at the patient-oriented endpoint, you see that there is an increase every year of these events. But in terms of the device-oriented endpoints, the curve is quite flat. So you see that we have, for example, 3.2% of events, which divided in 5 years is very, low yearly rate of event. And the same, so was seen also for the target lesion revascularization. So the benefit of the everolimus stent in terms of this endpoint, which was still significant at 10 years, but was gained during the first year after the implantation. After that, you see that the 2 curves are quite flat. This could be explained by the fact that during the first year, there is the healing process. So following this stent implantation. And once this healing process is over, so we don't see actually any advantage of one stent on the other, which is quite reassuring because in the end, so we don't see, I mean, neothrosclerosis, or the fact that if some strat is still uncovered, so this may translate in an increase in target lesion revascularization, or even indefinite probable stent thrombosis, as you can see here, in which the story is more or less the same. So the advantage, again, of the everolimus stent, so is much in the first year after implantation, but thereafter, so there is no benefit of one stent of the other, and especially looking at the windows between 5 years and 10 years, you see a very low rate of event, so less than 0.1 or 0.2% of event per year. So it is, I mean, quite reassuring. These results from the examination trial were also confirmed by the Comfortable. In the Comfortable study made by Lawrence Raber, Stefan Windecker, so the comparator arm to the bare metal stent was the myolimos routine stent, and you see that there was still much better performance of the drug routine stent as compared to bare metal stent, and also put the results of these two studies together. So in this sort of meta-analysis patient base, you see that the primary endpoint of the patient trend endpoint is in favor of drug routine stent, mainly driven by reinfarction and repeated revascularization, because the drug routine stent of second generation has a better healing process as compared to bare metal stent. One study which was published actually 2 years ago, so is the BioSTEMI. So the BioSTEMI was comparing, this is the first study comparing two stent, drug stent of second generation. On one side, the signs, so that we have seen so far in the examination, and the other one, so is the Orsiro, so sirolimus routine stent. So this study, I mean, was done by using a Bayesian model, which I guess that there are few people in the world so knowing what it is. But the fact that they're using this Bayesian model so allow them to include less patients in this specific study, and using patients from another previous study, which actually was comparing Orsiro and signs in a larger population, not really ST elevation MI. Interesting, I mean, is the primary endpoint of this study, because we have seen that the drug-eluting stent, everolimus stent, is very safe, is very effective. But looking at this study, so it seems that the sirolimus stent, so the Orsiro one, is even much better. So these, I mean, are results which are quite impressive. So I don't know if you, so how to explain, I mean, these findings. So maybe we can discuss later. Maybe some of you have some more knowledge about the Bayesian model, which to me, I mean, I'm one of the ones which are not, I mean, much knowledge about this statistical analysis. And then, so in the last part of my talk, so I just would like, I mean, to give you some insight about the bioabsorbable scaffold. You know? So years ago, so when I was actually studying in Rotterdam with Professor Rice, so we were excited about this technology, and we were thinking about how to use them in STEMI, because so they were a quite perfect stent for ST elevation MI. Because of this reason, so STEMI lesions are not calcified plaque, so are soft plaque. So we can have a reduction in the necrotic core because they are everolimus eluting. We can capping, so we can create a shield in an unstable plaque, which is the plaque which is usually seen in ST elevation. And we can also restore the vasomotion, the vascular pulsatility. And one example, for example, the shield of the unstable plaque was coming from some images like this. So here we don't have an unstable plaque, we have just a calcified plaque. On the left-hand side, after the implantation of the scaffold, you see that there are the scaffold struts on the top of this plaque. And a follow-up, which was 1 year, so you see that there is this tissue created on the top of the plaque. And once, I mean, the struts are bioabsorbed, we can imagine a situation like this, which I mean, it looks quite good. I mean, for a treatment of a culprit lesion in ST elevation MI. And this is, I mean, also fashion, I mean, topic, because looking, for example, at what has been presented by Greg Stone So in the prospect absorb, so the prospect absorb was actually a study treating in a preventive way a vulnerable plaque, which was a plaque with not much burden to be treated with an FFR negative. And the patients were randomized to the best possible medical treatment or medical treatment plus BRS, so the absorb. Of course, I mean, looking at the MLA, so this was worse for the BRS scaffold as expected, because we are treating a plaque, so we are creating a shield. And which was interesting to me was this. So looking at the randomized lesion related MACE, so it seems that there is at least some value, which of course need to be confirmed in a future trial. So this is just hypothesis generating that every time that we implant in a preventive way BRS scaffold in a vulnerable plaque, we may prevent event. So, but this need to be seen. What is so far known? So in the use of BRS scaffold overall in ST elevation MI, so it's coming from 3 different studies. The first one is the Trophy 2 studies, which was done 5 years ago. This was a study randomizing STEMI 1-1 to absorb all the science. And then, so the primary endpoint was the healing score at 6 months, so which is a score calculated by OCT. So the score is very simple because so it takes into account a different kind of steps in the vessel healing, like for example, uncover the strut, malapose strut, etc. And if the stent has some feature like this, so we have a healing score so higher, so that means that the healing score is worse. And every time that the healing score is low, so it means that we don't have any uncovered strut, malapose strut, etc. So that means that the healing process is fine, so it's okay. And looking, at the primary endpoint of this study, so it was set for non-inferiority. So, and it was interesting to see here in blue, so the absorb on the left of this curve, which means that the healing process following, so absorb implantation in STEMI was non-inferior to the science and was more somehow superior, although the P was 0.05. So was not, really superior. But it was interesting, to see that at least the healing process in this small study was not bad. Of course, the late loss was worse, as we have already seen in the compare absorb, which because because maybe of this, so the healing process was not worse than in comparison with the everolimus floating stent. However, looking at the hard endpoints, like for example, device-oriented cardiac endpoints or TLR. So we performed these studies comparing in a propensity way, so a cohort of STEMI treated by BRS implantation, and a cohort coming from the examination, so STEMI patients were treated by everolimus floating stent. And you see here at the results at 5 years, which were still in favor of the everolimus floating stent. That means that although the healing process at 6 months of the bare metals of the BRS was not bad, so at 5 years, so the results were bad. So there was an increased rate of TLR and also, an increased rate of stent thrombosis, as you can see here. And this was actually the end of the BRS. So not only in STEMI, but in general. And then, so the third study is the MAX STEMI. The MAX study was a trial published and presented last year at the TCT. So this study enrolled STEMI patients, randomized them 1-1 to or 0, so sirolimus floating stent, or Magmaris, which is the BRS made of magnesium. So with a different concept of the reabsorption as compared to the absorb. In this case, so the primary objectives was the 1 year vasomotion. That means that at 1 year, so all the patients were recatheterized, and we were injecting nitro to see if there was a vasodilation of the treated segment in the Magmaris group as compared to the Orsiro one. Here you see the procedural characteristics. Just want to highlight the fact that for the MAX STEMI there was higher rate of post-dilatation. So when we did this study, so it was clear that post-dilatation was really important for the BRS implantation in any kind of clinical scenario. And looking at the primary endpoint was superior for the McMurray's as compared to the sirolimus gluten stent. So we were able, to dilate more the artery in the treated segment. So every time that we had a McMurray's implanted, then an Orsiro. And here you see, some images. Here you see, for example, a McMurray's 3.520 implanted in a mid portion of the LID. So at 1 year before nitrates, and on the right-hand side, at 1 year after nitrates, you see that there was a dilatation of the artery. And here again, another 320 McMurray's implanted in a circumflex. So before and after nitrates, so you see that actually, so the hypothesis of the study was correct, because we were able to demonstrate some vasodilatation, which is quite clear to this, in these images, so implanting a BRS. Of course, so there was a price to pay for this vasodilatation, so which was the late luminal loss, so which was 10 times higher for the McMurray's as compared to the sirolimus, so to the Orsiro stent. And looking specifically about the fact of this, if this late luminal loss was translating in an increase of events, so this was actually the point. So clinical events were higher in the McMurray's as compared to the Orsiro. And what was curious is to see, the shape of this curve, because you see that this curve actually separate around 1 year, which was the time of the 1 year angiography. Because I remember, so we were doing the angios of this patient, and sometimes we were seeing some, a huge late loss. We were performing a FFR, and the FFR was positive, and then so we were treating the patients. So because of this TLR, which was related to the fact that the patients were back in the cath lab for the purpose of the stent. Because as you can see here, so there was no difference in cardiac death, no difference in target MI, and no difference in definite thrombosis, but all the difference was in terms of target lesion revascularization. So this, is my presentation. I guess that we can resume into 3 different points. So the first part is that the second generation Dazzling stent are so far safe and effective in STEMI treatment. So I guess that we don't have, to have any fear about this device. But what is important is that maybe we have to go beyond the stent choice, which is the outcomes beyond the 5 years. So as we have seen in the 10 years follow-up of the examination, so we see that these events are not related to the stent. So we need, something for secondary prevention in these patients. And last, so the BRS are so far not recommended in STEMI treatment. So that is something which is true. Despite, although they have, many theoretical advantage to me. So if at any point in the future, so they will be back, so in the clinical field. So I guess that it will be interesting, to test them again in STEM. So I thank you very much, and I'm ready and happy, to take any question you may have.
Thank you, Salvatore. That was really superb and an excellent overview of all the clinical data for stents and how we've gotten to where we are in STEMI. I'm going to let Manaf, is one of our interventional fellows. Let me introduce you to him. You see him there. And I'm going to let Manaf maybe ask some of his questions and take some of the questions from the audience. Please, if you have any questions, just put them in the chat and we'll get Salvatore to give you his opinion on them.
Thank you very much, Dr. Brugaletta, for that great overview. As somebody who's kind of been brought up in the current drug-eluting stent era, it was really nice to go back and see how we got to where we are. So thanks again. One question I had in that is in regards to the type of polymer on the stents. Sometimes we see these designations of durable and bioresorbable polymer. Is that a distinction that we should hold high in our minds, and how should we think about that? And if you also have any comments about polymer-free drug-eluting stents and where they fit in this.
Yeah, I mean, I remember polymer-free stents first generation, which was the Yukon one, and that I remember that we were putting a spray, sort of a spray on the top of the stent, and they were not working really properly. So I guess that
it was even more restenosis.
Exactly. So to me, I mean, the bottom line is not, I mean, it's polymer free, but I guess that we have so far enough data about permanent polymer and bioresorbable polymer to say that both are safe. So then we may discuss maybe if a polymer, durable polymer is better than a bioresorbable polymer. And I guess that this question, so it's difficult to have an answer to this question because the data are not, I mean, in favor of one or the other. The only study which is comparing a durable polymer to biodegradable polymer is the STEMI that are presented. But I'm really wondering if the healing process following biodegradable polymer, so stent implant, is much better than durable polymer. This was actually one of the reasons why we performed the 10 years follow-up of the examination trial, just to see if the durable polymer may cause some problem after 5 years. And actually, we have seen that the stent thrombosis rate, which is maybe more the point more related to the presence of the durable polymer, was really low. So the fact that so there is a durable polymer doesn't make, I mean, any worsening situation after 5 years. But I mean, I'm not in favor of a polymer free, because I guess that those stents, so Azim also told us, so I remember that were really the worst in the field. So I think something, so if someone want to use a polymer free, so we need a different concept. So maybe in the future there will be a new polymer free, much better. But I mean, I'm not in favor of a polymer free.
Right. I see.
Thank you for that. Yeah. Another question that came in the chat is your opinion on the safety of drug-eluting stents with abluminal coating in light of some data showing higher rates of acute stent thrombosis. So I guess I'm not sure what the abluminal coating is.
The abluminal coating is a drug-eluting stent with the coating of the polymer and also the drug elution just on the outside part, but not on the inside part. So the one that I know is the schizophrenic stent, which is the combo, which is a stent which has abluminal coating on the outside part and some CD34 monoclonal antibody on the inner side. I mean, to me, as I said before, so it doesn't matter where the coating is. So of course, I mean, thinking about the theoretical advantage, of course, so we need just the coating, so in the contact with the vessel. But so if there is no side effects of having a coating in the circumferential of the stent, because at the end in the luminal part, so it just washed by the blood. So I will not be, I mean, in favor of abluminal coating because it's better of the drug-eluting stent. I guess that this is data which the colleagues suggest is coming from a study which is not just related to STEMI, but is related to any kind of situation in which these drug-eluting stents were implanted.
I mean, the other big stent right now, and maybe Sajan, who asked the question, maybe if you could be more specific about which stent you're referring to, that would be helpful. But the other stent with a Abluminal coating that right now is being tested in a large global clinical study is Abluminus, right? Which is the stent in India, which is sirolimus coated. It's abluminal only, Manaus. It's only on the surface that's touching the vessel wall, and it's unique because the balloon that it's mounted on is a drug-coated balloon. So the thought is that you're getting at the edges drug as well of the stent, and that you're getting more uniform drug distribution. We don't know yet. They're doing a large global clinical study right now. Roxana Miran, Colombo, I think Marie-Claude Maurice are all involved. And so maybe we'll have some clinical data on that. It's specifically in diabetics.
So Sim, one of the things about bioresorbable polymers is what people don't realize is that as the polymer starts to absorb, sometimes actually the polymer outlasts the drug. So the thing is, the important thing is that the drug has certain level of synchronization with polymer absorption. Otherwise, once the drug is gone, let's say according to the release profile, 28 days, 45 days, if the polymeric degradation process elicits inflammation after that period, you actually pay your price later on. And we've done a lot of comparative studies, and you see that with bioresorbable polymers, you pay upfront. Because essentially what happens is you blow new intimal formation, then you have a little bit of catch up and then continues to grow. We draw with a more stable polymers where you get a more, control response over time. So that actually pro-inflammatory effect of polymer degradation is something that is being difficult to overcome.
That's interesting, yeah.
And I totally agree with you, because at the very end of the stent is not just a polymer. So it's a sort of team working. So it's the polymer, so together with the best metal, together with the best drug. And one should be, familiar with the others. They have to know each other, because otherwise, if you have a very good polymer but a bad stent, so it doesn't matter. So.
Yeah, so Sajan actually responded to our question, because he made the comment. He said he was referring to data from the cardio-based burn registry with the Synergy stent that showed an increase in acute ST rates with Synergy, not in the context of exclusively of STEMI.
Yeah, I know the study. So actually, the Synergy, I'm not sure if there is just a Abluminal Coating. If you can help me. I guess so. It's a biodegradable polymer, but I'm not sure it is just a Abluminal Coating. So I have seen this registry, and I was also impressed. By the acute stent thrombosis rate. So it's something that I don't see. In my practice, because I use Synergy. Much, but I don't see. This acute stent thrombosis rate, which was seen in the burn registry.
Well, enough.
Thank you. There's an interesting question from Dr. Menegas in the chat about implantation of stents at high pressures, and whether this, in your opinion or review of the data, is related to restenosis or stent thrombosis rates in the way that it may affect vasovasorum or the endothelium in general, when specifically implant pressures versus, let's say, nominal. Any particular comments about that?
Yeah, the vasomotion is a very tough topic, in the sense that, so first of all, we were thinking about the caging of the artery. So due to the fact that we were implanting a metallic stent, and we were thinking that every time that we implant a metallic stent, so we cage the artery and we don't see any vasoreactivity because of this. But then, so Patrick Rice came with the Absorb, I guess it was the Absorb 2. And in that study, so we were seeing some vasomotion. So even in the metallic stent, where there was this caging. So when we pass to the bioresorbable scaffold, I guess that there are some problems in the methodology, because looking at the QCA, to me the QCA has some limitation to see if this is a real vasoreactivity or not, because the contrast can die, inside the lumen, and maybe so there is an effect which is going beyond the eye of the operator, the QCA, methodology, and that is the reason why we see sometimes vasoreactivity in a metallic stent where we don't see. And regarding, this high pressure stent implantation that can have some effect on the vasovasorum, I don't think that is the situation, because vasovasorum will be always there. So either if we implant a pressure stent or low pressure or metallic stent, or etc., etc. So in case, for example, of the Absorb, so because there was a everolimus routine stent, we were studying the fact if everolimus routine stent were so the everolimus was actually having an effect only on the neointima, so on the fibrous tissue, but not on the small muscle cells. So that means that the small muscle cells were preserved and were able so to react some stimulus like nitrates, acetylcholine, etc., etc. The same so can be seen also for the sirolimus, at least looking at the results that we have found in the max STEMI. So although I mean there are many factors, so I mean to take into account. So the drug, the QCI limitation, to my opinion, in seeing that if there is still a real vasodilatation or is a QCI effect. That is the reason why I brought to you some cases, because in that case was quite simple, to see that there is still a vasodilatation or not. But looking, specifically at the BRS, I guess, so it is not vasa vasorum, but preservation of the small muscle cells, because the small muscle cells are those who can dilate or not the artery.
Right.
Thank you. Any special considerations for graft PCI in STEMI, vein graft or mammaries?
That is a good question, because so in my practice, I always use a drug-coating stent because it is the first stent that we see. We use always to have it. So in 99% or maybe 100% of our practice. So data from venous vein graft are not clear because it seems that the bare metal stent so is more or less the same as a drug-coating stent. So then we can have two different considerations. So to still implant a drug-coating stent. One is that at least is not harmful, so that we don't have any side effects. And the second could be also the price. So in terms that if you are a drug-coating stent more expensive than a bare metal stent, you are treating a venous vein graft STEMI. So maybe you can implant a bare metal stent, which will be safer as the drug-coating stent. But again, in this clinical scenario, so there are no data. So what we know, so is a sort of big data. So many patients with different clinical scenarios, not only STEMI but in general, venous vein graft disease.
And then I see Minato was also.
Any role
Yeah, go ahead.
for drug-coated balloons in STEMI, let's say in the case of neoatherosclerosis inside an old stent or something like that?
Yeah, Juan for sure. So we'll tell you more about drug-coating balloons. So to me, doesn't have any rationale behind using a drug-coating balloon in a ruptured plaque, because if a plaque is ruptured, so I will not see any role of drug-coating balloon. So at least there is nothing, no. So if, for example, so we have a STEMI due to thrombosis, so that could be a role. So if we do an imaging and we see that there are problems, for example, with the neoatherosclerosis in that case, that I will feel more comfortable, to use a drug-coating balloon in that specific scenario, because I can imagine that the stent was making a restenosis, and this restenosis at some point, so it was so high, so creating maybe a vulnerable plaque, or rupturing with a vulnerable plaque, or maybe it was just the restenosis, so the excess of tissue creating the ST elevation MI. I don't know, if Juan has a different opinion or
DCB
in acute MI.
In acute MI.
Look, so I wanted to bring up another topic along the lines of balloon use, and is the use of no stents at all in acute MI. Because some people have suggested that acute MI, a proportion of them come from non-obstructive lesions that actually rupture, and the problem is not obstruction, but it's just a plaque rupture. And of some people that is a very interesting concept, that they just go reperfuse the artery, give anticoagulants, and then just cool things off. And some actually have even done angiographic control. 24 hours later, the vessel is, it's a lot of work, but sending the patients home without stents. So that's why the balloon-based approach is actually quite appealing. The only problem is, number one, till now, we only have paclitaxel-based products that we know as a drug is being inferior to sirolimus, at least in the coronary territory. But on the second thing is you cannot overcome the problem of needing a scaffold effect, which is our biggest fear, right? You balloon an artery, it looks okay. You send the patient to the ICU, and then the patient gets, abrupt vessel closure at 12 hours, and actually you made something worse. And that has been our fear. I don't know if maybe it's because the historical context of the people who trained us that said, look, I mean, balloons only do not work. But to be honest, I still think that is actually an appealing concept and interesting concept to do the research side of things. And but it's still, it's a little bit concerning from the technical point of view, not for the drug delivery because you're going to deliver drug, but it's more for the practical point of view. Proximal LAD, unprotected, ballooned, leave it alone. I don't know if people will have the appetite.
Yeah. Because that's the thing, right? I mean, the data for drug-coated balloons in de novo disease is actually pretty good. I mean, the rate of acute vessel closure, which was the whole reason we invented stents, right?
Exactly.
I mean, we didn't invent stents to treat restenosis. We invented stents to prevent acute vessel closure after POBA, right? And interestingly, it's amazing when you look at all these DCB studies with de novo disease, we leave small dissections behind. And there's the rate of acute vessel closure and acute MI is actually pretty low. Now, no one knows why. I mean, people think it's maybe the high dose of drug that you're delivering to the wall has some effect because the dose you give with a drug-coated balloon is much higher acutely than you give with a drug-eluting stent, right? Or it's the antithrombotic therapy that's gotten so much better now than there was, 30 years ago. The problem, though, is when you say, even to say people like me, who's a big believer in drug-coated balloons for de novo disease, to use it in a proximal LAD, I feel uncomfortable. Right, I want to sleep well at night, and sleeping well at night means I stick the stent in. I don't think about it.
And remember, in a trial, you only need 2 cases in 100 to be inferior against drug-eluting stents in the acute MI setting.
But what you said is actually the rationale behind the BRS in STEMI, because the BRS actually has a sort of delivering some drug and then disappear. So creating a shield in order to avoid vessel occlusion, so acute vessel occlusion, and then disappear. The problem is that, so maybe that is not the perfect way, to deliver the drug, but it's more or less the same, no? That we are saying.
So let me ask you both this. I mean, it's a little bit off topic, right? But it's probably the only presentation in our CAT meeting we're going to discuss this and hypothesize about it. So, Salvatore, me and you have published lots and lots on BRS. One has actually helped develop a BRS and bring it to clinical study. What do you guys think? You think BRS is going to come back, or its time has come and gone?
You want me to answer you first? I mean, personally, so I like BRS. I mean, I like the concept. No, I like the fact that every time that we treat a patient, the patient always asks. The first question is when I will eat, of course, and the second one is so I have to change. I mean, my stent in some years or not. I mean, I would like, to be able to say to the patient, no problem. So this stent will disappear. So, and then, so you will see, you will not have any problem. Also because sometimes, so we treat STEMI with primary PCI with just one lesion, very young patient, 40, 45 years old. So, and that is the reason why I would like, to see BRS again in the field. Even saying that, so I guess that the story so will be very difficult, because the problem to me is investment of big companies to this concept. So that is the problem. So I don't know.
Well, look, I honestly believe that bioresorbable scaffolds are the best technological approach for coronary interventions. And what we have seen with some of the data presented, the cases that Antonio has presented with, lung disease, and when they absorb,
full plastic jackets.
It's unbelievable to see the potential the technology has. Also, I think that we cannot really judge the future of BRS based on the BVS experience, because other polymers are very good. And you've seen some of the studies with our devices that the data actually looks pretty good. But the problem is, as Salvatore said, this field is driven by financial incentives, right? And to be able to achieve the level of sophistication that metallic DS have right now is going to require billions of dollars in investment to develop what is today a commodity product.
Yeah.
So I don't think that actually, at least in the near future, companies are going to have the appetite to develop these technologies to compete against drug-eluting stents, unfortunately. Yeah.
So Manaf, for you, Shun, the fellows, this is an important point, right? While there may be some clinical utility, the economic side of this just doesn't make sense, right? Because for a BRS to come back, it's going to have to be it's going to have to cost more than a drug-eluting stent. And when you think about the fact that, maybe not Salvatore, but our friends in Germany pay €100, okay, for a drug-eluting stent, okay? It's hard to see how these big companies find the money to fund, a big clinical study to bring this technology back. So unfortunately, even though there may be better, technologies, even Abbott has a better BVS that's thinner strut. It's just hard to think about how we bring this back.
The battle actually went for BTK. So now BVS is running a big trial on BTK, and 2 other companies already are in the BTK territory for that particular application.
Right.
I mean, we are positive. So maybe next year, or maybe in 5 years, we will have again this talk.
Yeah.
So with BRS or something.
Manaf, did you have other questions? I have a last 2 questions for Salvatore, if you don't have any.
Sure, go ahead.
So Salvatore, do you still use bare metal stents in your lab? And if you do, when?
We still have a bare metal stent here in our lab. I don't know where. And but I'm 100% drug-eluting stent.
Okay, great, thank you. When you seeing a patient comes in, STEMI, large anterior MI, needs probably 2 overlapping drug-eluting stents. You don't know much about the patient, he's in pain, about compliance, adherence. And you're thinking about safety and stent thrombosis, is there a stent you choose? Or do you think it's become very much a class effect?
My feeling is that it's a class effect. So because so years ago there was the first stent showing 1 month of DIPT, which was the BioFreedom. Then actually you show the Onyx one, and then so it became available. They are becoming available data coming also from everolimus stent, science, etc. So to me, it's a class effect for the 2nd generation drug-eluting stent. So I guess that every time that we have a patient, a STEMI patient, where we have to implant many stents. So first of all, we have to think about if this patient really need such higher amount of stents or not. Because, for example, if you have a bifurcation with the 2 stents, I always try to treat in the best way, in the easiest way as possible. But then, so if we have to implant many stents, so any kind of 2nd generation DS, it doesn't matter.
Okay. So just to follow that, in your practice, and it sounds like we do exactly the same thing. I mean, on a day-to-day basis, right? And I think this is important for the fellows. How do you choose stents? I mean, you like me, you probably have 3 or 4 stents on the shelf. And some days for me, it's just maybe the way I wake up that morning, I have to admit. Like after that, give me a sign. So give me, whatever. And do you have, in your own mind, do you have an algorithm or something that for certain stents, in a STEMI, I choose this. If it's very calcified, I'm going to choose this. If it's a left main ostium, I'm going to choose something else.
Yes, I mean, this talk also will be recorded, no? So everything that I will say, I will be saying. No, I mean, to me, there are stents like, for example, the Science or the Onyx, which are for any kind of situation. So calcified lesion, bifurcation, maybe the Science is a little bit better than Onyx because of the cells. And there are other stents like, for example, the Synergy with this Cupertino effect. So the fact that they can be shortened. so that I will not implant for maybe in ostial lesion. You know, although I mean they have improved, etc., etc. But I'm not. I mean, I will not try.
Mhm.
So, but to me, the best in class so are good for every kind of lesion. Do you have, I mean, a preferred stent?
I don't. I mean, I really think the stents have become so good. The comparative data is so similar, right? I mean, the one thing I guess I've been disappointed a little bit with is the biodegradable polymer stents, right? Because that promised conceptually to be the stent that was going to give us very low event rates long term. And I've not convincingly seen that. Even, all the meta-analyses and network analyses all pretty much show that I think most stents are equal nowadays. They've become so good.
No, and they will be, I mean, even better, but not because the stent will become better, but they will be, so to my opinion, better result in terms of the APT. So now we have 1 month. So I guess that this time can be shortened to 1 week. So like,
Right.
for example, every time that we implant a drug stent in a patient with a oral anticoagulant, we just have a very procedural, so triple therapy, and then we switch to dual therapy. So I guess the next step, so maybe we can ask the expert like Marco Valgimili, Roxana Moran. So they are already thinking about a study with this very short period of the APT, because to me, so we are really at the top level of innovation for the drug stent that we have.
Absolutely. I'm going to ask you one last question that just came from the panel. Sorry, from our participants. We have participants from all over the world, Salvatore. And so that's why I want to address this question, because it's a question we don't face in the US, and probably you don't in Spain. But our colleagues who work in other countries may face this. So Zain, who is always joins us for these talks, thank you for always joining, Zain, asks a question that's relevant to his country, I guess. He says, can stents be used after their best before date is over? Since being a poor country, we are given stents with short expiry as granted by the companies. Although we don't use, this is a question that he'd like to know the answer for, because they face that in poor countries, which I'm sad they have to face that, but it's a reality of the world.
I guess that if you don't have, I mean, any other alternative, so you can do it.
Probably still better than a bare metal stent, right?
Exactly.
Yeah. Okay. I think so too, Zain. When I worked in South Africa, we also had this challenge. Drug-eluting stents cost 2 to 3 times the price that they cost here in the US when I worked there. And sometimes we were faced to make the best use of resources and not waste. So I don't think, we can't say you must do this, but I think when you're in those situations, you do what's best for patients. Thank you. Grazie, Salvatore. Thank you so much. This was a great morning, great discussion as well at the end, and great insights from Juan as well. Manav, thank you. Thanks, everybody, for joining.
Thank you. Thanks to you.
All right.
Hope to see you soon in one Congress.
I know. Look forward to